really excited to be here today. We can tell who the favorite of our barber is, though, because they always take a little too much off the top for me, and Brian always has the extra. We've worked together for many years, and I can truly say that I consider it the greatest privilege of my professional career to be able to work with Dr. Hoelzer on a daily basis. He's an amazing physician and an even better human being. But our tenure together goes back even to when I was a fellow. He was my fellowship director, and so I just want to give a forewarning that if at any point he says some random statement like, you know, a Diet Coke would be good right about now, and I just say, you bet, sir, and I walk off the stage to go get him one, just go with it, because just like leprosy, the old habits of fellowship die really, really hard.
And I'm really honored to share the podium with Dr. Freeman. It's been said before that if you want to be good at something, surround yourself with greatness. And that's really what I did with Dr. Freeman when joining his practice, was try to join up with somebody who was great. And least you think I'm feigning humility, I'll tell you that when I first came to his practice, he'd been in practice for a little over a year. I'd been practicing at the Mayo Clinic for about 14 years, and I came and joined him. And he had been truly one of the best fellows I'd ever trained. But he was really busy, so some of his patients got kind of put onto my schedule. So I'm doing a procedure on a gentleman that had always had Dr. Freeman, and he was nervous. He said, you know, Dr. Freeman always does my procedure, and he's really good at it. And he said, but the only reason why I'm trusting you is because your schedulers told me that you actually trained him. So we do his procedure. The patient gets off the table and says, well, I think this is an example of the student becoming the teacher. Dr. Freeman's a little better than you. And I have to admit, I had two emotions at that point, because if you're in academic medicine, really your goal should be to train physicians that are better than you. So for a moment, I felt just a little bit of pride that I had accomplished what I had wanted to accomplish. But there was a little part of me that was like, you maybe could have saved that to tell somebody else after I'd left the room. So the old adage that if you can't do, you teach, might be true in this situation. But I've been honored to be with him. We obviously have a great relationship. This was our first Christmas card we sent out when we first joined up teams. And we sent this to Dr. Gillette, who spoke last year. And immediately within a few days, we get an email back to us or a text back to us where he had altered the picture and changed it to look like this. And I think it is kind of true. We get along really, really well. So he's definitely my work spouse for sure. By way of disclosures, Dr. Freeman doesn't have any. I have a few disclosures. I am still involved quite a bit with education, so most of my disclosures revolve around me doing education with fellows, teaching them procedural and surgical skills. So, and maybe the other disclosure is those who can't do teach. You should probably know that because I teach a lot.
When we look at the incredible advances in science and in medicine in today's world, there are still certain questions that we may never get answered. And so here are a couple examples. One is, you know, which state has the best form of frozen water? Utah snow or Hawaii shaved ice? That's a tough one. You got skiers in the room, but when they put the ice cream at the bottom of the shaved ice, I mean, that's a tough one to beat. Another one is, why do patients with the most tattoos seem to have the worst needle phobia? Every day we run into this one.
Now, I want to have a pause there for a second, because if there's somebody in the audience with a tattoo, and there are a few that are offended by that, as the one person on the podium with an actual experience with the tattoo, I can say from experience, the procedural needle is much scarier than the tattoo guy. So I'm a little offended by that. And the final question is, what exactly happens in a pain clinic?
So we are very well aware of the stigma associated with pain clinics, right? You can imagine yourself sitting with your primary care doctor, they're going through all of your chart, and they look at you and say, you know, I think I need to send you to the pain clinic. And depending on your interaction with pain clinics, there are several different scenarios that can go through your mind. This is one of them, where you look at it and you think of that classic Florida pill mill, right? The line's going out the door, everyone's going into the building with a handful of sweaty dollar bills, and they walk out with a handful of sweaty pills, and you think, please don't send me to the pain clinic. I don't want to get hooked on meds. I don't want to get addicted. If I get addicted, I'm going to start stealing from my family. I'm going to break the law. I'm going to end up in prison. I would not do well in prison. I'd be really popular, and I'm pretty sure prison popular is not the same as high school popular. So please don't send me to the pain clinic. Or maybe you think of this, and you say, please don't send me to the pain clinic. All they're going to do is injections, just shot after shot after shot. They don't want to think about anything else. I have tons of tattoos. I'm terrified of needles. You know, I kind of leaned into the tattoo thing a little much.
Don't do it anymore.
So I gotta apologize to anyone with tattoos. I mean no offense. Gary, that unicorn tattoo that's hidden, it's in the vault, buddy. Secret's safe with me. Secret's safe with me. The unfortunate thing is that both of these stereotypes are well earned by pain clinics. This is historically has been the problem, but we are fortunate to live in an area where the pain clinics are really phenomenal at combining all of the methods that we have available to try and improve patients' pain and functioning.
And Dr. Partridge's talk this morning was really a perfect segue, I think, into the things that we're going to talk about, because if you look at websites, pain clinics treat a number of conditions, and that really kind of goes to the point that pain affects almost every area of the body, and almost everybody in this audience and everybody in the population are at some point or another going to suffer from even a version of chronic pain. It's treated with a lot of things. So there are a lot of medications that are used. We're not going to talk a lot about medications today, but they are an important part of the toolbox that we use to try to help patients that suffer from chronic pain.
And obviously, they're the procedures that we perform, and these can be as superficial as trigger point injections to as deep as celiac plexus blocks. But really what it comes down to is that person, that individual that's sitting in front of us in the clinic. They're suffering. They have had pain that's now disrupting their daily life. It's changing their mood. It's affecting their relationships, and they're asking for help. And so we sit with them, we have conversations with them, we find out their symptoms, their history, we look through their imaging, we gather all that outside information, we put it all together to come up with an accurate diagnosis, and then we pair the most appropriate treatment to that diagnosis in the hopes of helping them get back to live the life they want to.
And I want to take a moment to just pause to make sure I emphasize that when we evaluate a patient, we're trying to look at every modality we can to help with their pain. So we're big fans of chiropractic care and of physical therapy. We utilize medications with protocols to try to be as safe as possible with those medications. We utilize injections. But because we have such a limited amount of time today, we're really going to just focus in on 3 key procedures. And our point behind these procedures is we think, 1, these are very impactful in patients that suffer from pain. And 2, these are procedures that everybody in this room, regardless of what your background is, are going to see patients who have potentially gone through one of these procedures. So to have a little bit better understanding of actually what that is, we're going to try to paint those pictures. So you're going to see some videos of these procedures actually happening, how we apply them to patients, and why we apply them, hopefully so that you leave here with a little bit of information about what we do.
So let's talk a little bit about kyphoplasty. First, when do we do this procedure? This is a procedure that we do for acute or subacute compression fractures of the spine from T5 to L5. Ideally, it's done within the first 6 to 8 weeks of the fracture. And the reason why is because, especially in these osteoporotic patients, you may start with a fracture that has a 20% height loss, but over time, it goes to 40% height loss, then 60, then 80. And at that point, you've created such a significant biomechanical change in their spine that the options as far as reversing that are very limited.
So what is a kyphoplasty? Really quite simply, it's just a process of creating space near the fracture and then stabilizing it with cement or injecting cement.
And the goal of it is twofold. First, we're trying to stabilize the fracture, prevent further collapse. And the second is to improve the pain that the patient is experiencing from the fracture itself. Now, if we look at the groups of people who are at risk for these types of fractures, it's postmenopausal women, anyone over the age of 50, those who are very inactive, those who smoke, and those who have cancer. And so we think of the little old lady who's hunched walking down the sidewalk as the classic patient. But the reality is these people get fractures too. These are the traumatic version of them. Or these people get fractures, those who really like to relax and spend a lot of time on the couch. An interesting new idea in spine management is this idea of number needed to treat. And what it is you look at an intervention and you see how many times you need to do that intervention to prevent either mortality or significant morbidity. And when it comes to common treatments like aspirin, you have to treat 3,000 people with aspirin in order to prevent 1 stroke. You have to treat 1,600 people with aspirin in order to prevent 1 heart attack. Another example is TPA. TPA is that clotbuster medicine that if someone shows up into the hospital with an acute ischemic stroke, they give them this medicine, it helps to dissolve the clot, and everyone goes home happy. You have to treat 15 people with TPA in order to save 1 life at a year's time. Interestingly, kyphoplasty is the exact same. Every 15 kyphoplasties that are performed, 1 life is saved at a year's time. And this is really interesting to me because you can't imagine anyone going to the hospital and having a stroke where they don't offer TPA as long as it's medically indicated. Yet people every day are being seen for compression fractures, and not alone is kyphoplasty not being offered, often it's not even being discussed as a treatment option for them.
So, I mean, really the analogy I like to think of is the hip fracture. So if somebody has a fracture and they're in a lot of pain, and again, this hinges on them having pain. If they have a fracture and they don't have pain, it's a different pathway we take. But if they're having a lot of pain, then they're not breathing, they're not moving, and they start down that degenerative or loss of muscle mass and degenerative process pretty quickly, which can impact their life. So we take this procedure and this condition so seriously that actually Dr. Freeman and I have spots blocked out in our schedule every week, so that if a patient needs a kyphoplasty and it's authorized and they're in a lot of pain and they're not functioning well, we don't have to say, okay, well, our next available is going to be 7 days away or 10 days away. We have every Tuesday set up and every Thursday set up where we can just do these procedures for patients because it's such an important procedure. So now let's learn about it.
So how do you determine if a fracture is acute or chronic? This is really important because kyphoplasty is approved and useful in acute fractures, not in chronic fractures. And MRI is really the gold standard is how you figure this out. So this is the same MRI in the same patient. There are just 3 different sequences in that same MRI. So on the far left of the screen in the T2 image, this gives us the big picture view. So you can see the L4 vertebrae, which is lower on the screen, is smaller. It's compressed compared to the L3 above it and the L5 below it. And if you go to the top of the screen, that T12 vertebrae is also centrally compressed compared to the L1 vertebrae. So you look now at the middle image. This is the T1 sequence. This shows that the superior end plate of L4 is darker. That means that there's some inflammation, there's some fluid buildup in that end plate, whereas there's no color change in T1. And really the key sequence is this stir sequence, and that shows inflammation. So inflammation or edema, it makes it bright, whatever has that going on in it. So the L4 vertebrae lights up. It's brighter than the L3 and the L5, meaning that is a acute or subacute fracture that is appropriate for kyphoplasty. The T12 vertebrae is the same color as the one around it. That is a chronic fracture. We should not treat that with kyphoplasty. So the basic idea here is we take a needle, we put it through the pedicle into the vertebral body, we create a space in the vertebral body, and then we fill that space with cement. So we're going to go through a video. This is a kyphoplasty that we performed. We start by anesthetizing the skin and the subcutaneous tissues, and trying to anesthetize that entire tract that we're going to be using our access cannula. We make a small incision and we insert that access cannula, and the key is to keep it within those pedicle borders. If we go too high or too low, you're into the nerve roots, that's bad. If you go too medial, then you're into the spinal fluid. So we use our very small hammer, and right now the orthopedic surgeons are like, that's not a hammer. Right? We just very dainty, very dainty. Slowly advance that needle until we get to the posterior wall of the vertebral body. At that point, we plow forward. We know that we're safe for it, and you're going to be in bone the whole way. So we continue to advance that needle until we get to about the mid-vertebral body line. And as we're doing this, we're getting a lot of AP and lateral views to make sure that we're keeping that trajectory that we want. So we just give it a little tappy, a little tap, tap, taparoo, and work our way down. And once we get down to where we want to be, the center of that cannula comes out. So we remove the center of the cannula and we'll insert another instrument. In this case, I used a curved needle, and so we insert the curved needle, which really allows us to access all parts of that vertebral body. And we'll usually insert it several times. So we'll draw it and insert it several times and make multiple passes throughout the vertebral body to create various channels for the cement to go in, and specifically so that we can put the balloon into one of those channels. So we've removed the curved needle at this point, and we've inserted the balloon. And we can see it because it has those dots or markers in there. It's right in the vertebral body, both in AP and lateral views. So we connect our little handheld device and we start filling that balloon up with contrast. That way we can see it start to expand. It looks right where we want it to be. So we put the curved needle back in and start to inject the cement into that space. We can see that opening there, where you can see the darkening at the tip of that needle. That's the cement going in. We want to make sure it stays in the vertebral body, doesn't go outside of it. And once we're happy with the amount of cement that's in, we take the needle out. It's a small little incision that we close up with a steri strip. And all you're left with at that point is the cement that's in the vertebral body. And so that's a kyphoplasty. It takes about 20 to 45 minutes to perform, depending on how many levels you're treating. And if you're Dr. Hoelzer, he does it in 10 minutes. It takes me an hour, so between the two of us, we're right where we want to be. This works about 85% of the time in reducing the patient's pain, and in half of those patients, it's immediate. So they stand up after the procedure, and their pain is gone.
So we're going to switch gears now and talk just a little bit about spinal cord stimulation. And last year there was a great talk by Dr. Anderson, who's a big advocate of spinal cord stimulation. So I know most people are familiar with it, but we're going to talk a little bit about sort of the history of it and then also show you one of those cases.
So let's go back to 1967. I wasn't alive yet. Some were, I was not. It was an awesome year. Great things happened in 1967. Thurgood Marshall became the first black American to be part of the Supreme Court. It was the year the very first Super Bowl was ever played, and only slightly less known in the annals of history, it was also the first year that a spinal cord stimulator was implanted. And this was done by a neurosurgeon in Wisconsin. He had a cancer patient who was struggling with pain. So he inserted this device, and amazingly, it worked. By stimulating the dorsal column of the spinal cord, the patient's pain was improved pretty drastically. Now I know what you're thinking. It's the 60s, a new medical technology, and you put these things together, and this device he used had to be super classy, like this level of 1960s classy, like super smooth. The reality is it was more like this level of 1960s classy. And if we're being really honest with each other, it was more like this level of 1960s classy. Like, it was not classy at all. It was big, it was bulky, it was difficult to program, and so even though the technology worked, it never really took off. And so as this really just kind of stayed at a baseline level until 1984, when the first fully implantable device came to the market. And at that point, people started realizing that this might be something that could be used on a regular basis. And over the subsequent 16 years, the devices got smaller, the technology kept getting better. And in 2000, the FDA came out with their indications for appropriate use of spinal cord stimulation, which then helped both physicians as well as patients be able to focus in on really what was the conditions that had the most evidence for spinal cord stimulator use.
So in 2000, we finally had FDA conditions, and then we've put this sort of red box in the middle there, because really for those next kind of 15 years, there weren't a lot of big advancements. There were advancements in the size of the battery, and there was advancements in sort of the configuration of the electrodes, but that was kind of where the advancements were happening. And several other companies came on board and started to use this therapy or manufacture these therapies. In 2015, though, the whole industry was really turned on its head, because up until that point, all we were looking at was sort of battery size and electrode configuration. But really some smart people started saying, well, what if we change the way the wavelengths are delivered to the spine, the way the energy is delivered? So things like high frequency stimulation, burst stimulation, all these new ways of doing stimulation came about, and it really changed the way we looked at how we could treat pain. Like, for example, diabetic neuropathy, a big study came out not too long after that, and then not too far after that, another study for non-surgical refractory back pain. Up until this point, back pain had been almost impossible to treat because of where the fibers ran in the dorsal column. So when you treated somebody with spinal cord stimulation that maybe had a previous surgery, really the question you had for them was, is your pain primarily in your leg? And if it was in your leg, we could probably treat it. But if it was in your back, it was sort of like the holy grail. We couldn't get there. So there were a lot of advancements in the last 10 years in spinal cord stimulation. And the analogy I use is, in 1984, this is what your phone looked like. And it was maybe helpful to make a phone call, maybe, not always. And this is what your phone looks like now in 2025. And really, the advancements are remarkable. And I think the advancements in spinal cord stimulation have followed a similar trajectory. In other words, the phone call is the last thing you use for this. It's everything for you. So there's really been some great technology advancements that I think have made this therapy more and more important in the treatment of chronic pain. So to make sure everybody understands what that is, I'm going to just show a video of this procedure happening. So previously to this part of the surgery, the incisions have been made. No muscle is cut, no bone is cut, but just incisions so the electrodes can go underneath the skin. Two 14-gauge 2E needles are then advanced down into the epidural space. In this case, it was at T12L1. And once the epidural space has been identified with the loss of resistance technique to make sure you're in the right spot and not too deep, not too close to the spinal cord, or you have to call Dr. Edwards to help you out. You start to then thread these electrodes in under intermittent or live fluoroscopic guidance. So we're just going to feed these electrodes up the spine, fairly painless procedure to do to a patient once you've gotten the incision numbed up and they're under a little bit of sedation for this, typically a MAC, not a general anesthetic. So the electrodes are placed not always in the same spot. It depends on what the patient's pain pattern is, where they hurt, what it is you're trying to treat. But in this case, this patient suffered from complex regional pain syndrome, and so we typically stimulate lower down in the spine, more like T10, T11. If it's back pain we're treating, it's often a little higher up at T7. But you can see that we take several views with fluoroscopy to ensure our electrodes are in the right space. We are in the right spot. We do some testing on the table to map out the spot and make sure they're all going to work. Once we're happy with the placement, the needles come out. So again, the needle was just used to access the space. We didn't have to go down to the lamina. We didn't have to dissect any muscle for this. The electrodes are in place, but we want them to stay in place. So now we have a little anchoring device that we can use. It goes over the electrode. It's taken down to the level of the paraspinal fascia so that it can be anchored to something that's going to hold it into place. And once it's in place, we'll use some ethibonds or a suture to kind of, a non-absorbable suture to lock that anchor into place, which is then also locked to the electrode to hold it into place. So I finished anchoring it there. Once we have it anchored, now we need to connect the pocket to where the battery is going to be to where the electrodes are. So you can see off at the bottom of the screen, there's another incision in the screen that I've made previous to this portion of the case. And once we've got those locked into place, I'm going to tunnel those over. And unfortunately, I should have changed my OR lights here because there's just the glare, you really can't see much. But that's just a little tunneling device. It's really a very expensive straw, depending on how you want to look at it, that allows you to get from your midline incision where the electrodes were placed over to the pocket where the generator or battery is going to be in place. And once you've done that, you want to irrigate copiously with an irrigation solution to clean out any blood clots or if there was any sort of bacteria in the place, but you just want all the debris out of both of your incisions so that you have a nice clean incision. You're looking for really perfect hemostasis because we know bacteria loves blood, and so we want to make sure that we have stopped any bleeding there. And then once that's done, we're going to hook those electrodes up to this battery. So they get hooked into place, and then we're going to finish the irrigation a little bit more, and we're going to close with just a multiple layer closure of both those incisions. And I'm just going to skip the last part of that. But that's the process of a spinal cord stimulator. So when you see a patient that's gone through that treatment, they'll have two incisions, one for the battery and one for the midline incisions. But deep to those incisions, there hasn't been any change to the anatomy. In other words, it's a completely reversible procedure. We haven't changed the bone. We haven't changed the dynamics of the spine, which is, I think, is an important part of it.
I can't help but point out, like, I watched your video and I watched my video ahead of time. Like, clearly one of us is shiny and one of us is basic. Like, mine was literally shot with an iPhone. And Brian's has, like, all these different angles and everything, like, just so shiny. That's great. We're going to talk a little bit about basivertebral nerve ablation. And let's start this conversation with a case review. So let's imagine you're in your clinic, you have a 48-year-old woman that's in the clinic with you, and she's complaining of low back pain. She's had it for a year. It's just gradually getting worse. She's tried physical therapy, she's tried anti-inflammatories, muscle relaxants, nothing's helped. So you decide to do a physical exam, and you find that her pain is worse as she bends forward. It does not change if she goes backwards, and neurologically she's intact. No abnormalities that they can find on that exam. So they've had this pain for now a year, and you're thinking, we probably should get some imaging.
So this is the MRI here to the right, and what we're looking at is modic changes. And I want to point out, Dr. Bowden gave a great talk this morning about the fact that people without pain can have degenerative changes on their MRI, and it's really important to know that. So we never want to treat the image. We want to treat the patient in front of us, but we're correlating this. So if this patient came in and said, yeah, I have pain occasionally, but it doesn't really bother me that much, and if I take an ibuprofen, I'm good, forget about those modic changes. But if they come in and they have vertebrogenic pain with flexion, anterior column pain, and it's debilitating, and it hasn't responded to physical therapy, and hasn't responded to medications, then you might want to pay attention to these modic changes, and there are different kinds of modic changes. And in this case, we're pointing out those modic changes. They're pretty obvious to see, so it's a nice biomarker of a process going on in the spine that you can correlate with what the patient's telling you.
What's crazy is for decades, we thought that these changes, if they caused pain, were very minimal as far as the pain that they caused. And so we started doing studies and found out that actually there's more nerves in the bone, in the end plate of the bone, than there is in the disc itself. And that as that degeneration starts to take place, that density of nerves increases pretty drastically.
And we know that for sure modic changes are painful. There's been great studies that show both specificity and sensitivity for modic 1 specifically and modic 2. Modic 3 are not painful. So you have to make sure you understand what kind of modic changes you're dealing with, and we're grateful for really great radiologists in our area that help us describe those and put it in their radiology report. But this has been a really important thing, and I should make a mention that Dr. Partridge talked about this procedure. It's also called intercept procedure or basivertebral nerve ablation. He talked about the frustration with insurance covering it, but it's now pretty widely covered with a few exceptions. But it's been important to me because I can still remember back when I was a fellowship director, I would give a talk to the fellows about modic changes. And I would go through modic 1 and what that was, and modic 2 and what that was, and modic 3 what it was. And I can still remember a fellow asking me at the end of this little lecture, hey, so what do we do for the different modic changes? And I said, oh, there's nothing you can do for him. And I could see sort of the crestfallen look on his face where he literally said, why the hell did we just spend 45 minutes learning about him if there's nothing we can do for him? And I said, well, you need to know him from the boards.
Brian. Language.
Sorry, that's right. Yeah, you did warn me. I said, you need to know for the boards, and so my job as a fellowship director is to teach you about it. But there really wasn't a lot we could do other than as far as interventions go for it. I mean, obviously physical therapy and chiropractic care, but there wasn't a lot we could do for it. And then fast forward now, there's this basivertebral nerve ablation, which if you look at the data is the fastest growing minimally invasive spine procedure being performed in the US right now, and is growing exponentially, and it's really kind of exciting to see the outcomes from it. So I'm going to show you a video. We have about 5 more minutes. We're going to show you a video for about 2 minutes of this procedure being done. So here we are in the operating room again. It's very similar to the kyphoplasty, so we won't have to go into a lot of detail. We're going to numb the track up. We need to get good pedicle access. So we start with this trocar here after making a very small 5mm incision that at the end will just be closed with a steri strip. You got to be perfectly on target. You actually have to be a little more on target for this than you have to be for kyphoplasty, because you need to target the basivertebral nerve. You've got to be right where the nerve is actually branching out. You want to get at the trunk before it branches out to a bunch of branches, or you won't have as good an outcome. So I'm taking a moment to get this lined up using a towel forceps to make sure my hands aren't in the radiation. And then I'm going to tap it in. And I don't want to be this guy, but I'll point out that my hammer's just a little bit bigger than Freeman's hammer.
It's not all about size, Brian.
Yeah.
Size
So
isn't most
we're going to just gently tap this into the pedicle. We're going to take multiple views because we have to make sure that we're exactly on target. You don't want to cause any sort of nerve damage. And so we're going back and forth between AP and lateral views as we work our way down to more of the posterior wall of the vertebral body. So we're not going quite as anterior as we go with the kyphoplasty. And so we're just going to tap that in. And as we work our way down, once we get down into the vertebral body in just a moment, you're going to see I'll use a J stylet to cross midline. And then we just use, instead of injecting cement, we're using a probe, a radio frequency probe, a bipolar probe that then we can ablate the basivertebral nerve. Now what's exciting about this is everybody here has seen a patient who's undergone a facet RFA before. And those have to be repeated about yearly because it's a myelinated nerve. The basivertebral nerve isn't myelinated. And so the studies that have been done on this, the initial studies were 5 years, and now they're up to 10 years on following up with those patients. And if they are a responder to this therapy, it actually doesn't have to be repeated, which is really kind of a nice thing. So you can see that probe going in. Depending on this case, we were treating 3 and L4, so we had to treat 2 levels, so you see me getting that second level ready to go. Takes about 40 to 45 minutes, and then the patient goes home the same day. It's usually just done under like a monitored anesthesia care, and they don't really have any restrictions afterwards, so they don't have to spend 6 weeks of being careful about lifting and twisting. They just have to listen to their body. We try to make sure they get back involved with physical therapy. They have all failed physical therapy before we can even do this, but once we've gotten them some relief, I mean, the reality is no pain problem, or no spine pain problem happens in isolation. So if they've had vertebrogenic back pain, they have probably have degeneration of their multifidus muscles, their facets probably aren't quite right. And so if we can get that vertebrogenic back pain improved and allow them to start having flexion motion more regularly, we want to get them back into physical therapy to strengthen those muscles.
So we come back to the question that we asked at the beginning. What is interventional pain management?
So really, if you look at this screen, we hope you'll take away the point of not just these 3 procedures, but that it's a lot of things. It's diagnostics, it's physical modalities, it's medications, it's injections.
A lot of it comes down to, I love looking at this chart because you look at the most of it and it's training, it's education, it's experience. But that last top left corner one is what I find to be probably the most important one, and that's the compassion one. And this is something that I learned from Dr. Hoelzer even when I was a fellow, how important it is to demonstrate compassion to the patients that we take care of. And using simple words and simple phrases, we can really express that. Things like, I believe you. I believe that you have pain. Because so many times these patients have gone to so many other places, they've been to so many clinics, so many treatments, and some of them have been told that they're making it up, that they can't find any explanation. We believe you. And then we're so sorry. I'm so sorry you're here. I'm sorry you're struggling. I'm sorry you're suffering from this. And I'm sorry that you're in my clinic, because it's never a good day when you're in my clinic. But we're going to do everything we can to help you feel better.
And with that, I would just mention maybe Dr. Freeman, I could probably use a Diet Coke.
I'm on
right
it.
now.